I'm Anthony Leeds. It's my pleasure to welcome you again to one of my conversations with colleagues. And in this episode, I'm going to continue my discussion with my colleague, Mr. Pratik Sufi, the consultant bariatric surgeon at the Whittington Hospital in North London. Mr. Sufi, thank you very much for joining us again. And we're going to continue our conversation by addressing the question of how good is the long-term evidence for the bariatric surgery, and that raises this question because last week we discussed the evidence that with all interventions, whether they're drugs or diets or surgery, we need to know what happens in the very long term. And for bariatric surgery, we've actually got more evidence, haven't we? Really good long-term evidence than we have for some of the medications. Could you comment on that, please?
Thank you very much. The best result that we have got, Tony, is from the Swedish studies. That clearly shows that bariatric surgery is beneficial, both in terms of the weight loss and weight loss maintenance, but also in terms of the metabolic benefits that we see in the remission of diabetes and reduction in the medication that's required, blood pressure, cancers, and of course nowadays there are also other studies that show that there is also reduction in vascular dementia, cardiovascular disease, etc. So there is no doubt that there is long-term huge benefit if bariatric surgery is done to patients in the right setting. Yep.
So you mentioned also comorbidities, and we know that while obviously aging takes place, even if you had your bariatric surgery 26 years ago, you're still going to slowly get old, and that will have an impact on the metabolic disease. But the evidence is pretty impressive for, as it were, remission of diabetes, big reductions of blood pressure, reduction of cardiovascular risk, and so on. But also another one, and we discussed this a little bit in a previous episode, renal disease, particularly associated with diabetes, seem to be reduced as well as a consequence of weight loss by bariatric surgery, and we now have greater understanding of the mechanisms involved there. So really there's a whole set of things, and you can show very easily, can't you, and there are papers in the literature showing that from a health economics point of view, this is a very effective intervention generally.
Absolutely. And there is no doubt, and this is our experience as well. Patients who have these operations, I mean, we started offering these operations in our unit in 2006. We see patients coming back from 7, 8, 9. We see some of these patients coming back with other problems. And maybe they have come in with some reflux disease, or they have come in for gallstones, and they're eternally grateful for the huge life-changing experience that bariatric surgery has offered them. Bariatric surgery does not mean that patients will not go on to develop the other health problems that we will all develop as we age, but it just makes much less likely. I mean, it is a very recent paper that has documented that the difference between diabetics and non-diabetics is at least 3 years in terms of life. We're talking here of productive life. We know that most of these patients have got not only one but multiple comorbidities. Cancer is very common, 3 times more likely in patients who are morbidly obese, and so any weight loss which can be sustained. So we're not talking about just a 6-month weight loss. Even that we know is beneficial, but if you can sustain a weight loss at 8 years, 10 years, it gives patients major advantage, even if they get some of this weight back 8 years, 10 years down the line.
Now, if you look at the pattern of weight change after surgery, there is a little bit of a drift up, isn't there? There's a big reduction down to about 2 years, and then there's a slight regain. But that doesn't seem to matter very much in terms of the long-term benefit, because the amount of weight loss and the reduction of dietary energy intake that is needed to achieve the metabolic effects, the blood pressure effects, and the inflammatory effects, which have an impact on vascular disease, are all achieved with a relatively modest weight reduction of, say, 15, 20, 25 kilograms weight loss. So bariatric surgery delivers weight loss, a little bit of slight drift up over 5, 10 years afterwards, but that doesn't matter. The long-term benefits are still very, very clear indeed, aren't they?
Absolutely. Health
Yeah.
benefits, apart from the weight loss benefit, and of course from the social, societal point of view as well. It is much better to have a patient back to work than having this patient dependent on carers. It is much easier if a patient can actually fit in easily into a bus seat or a plane seat than having to buy two seats to fly. So there are other advantages. Absolutely, there are great advantages, even
Yeah.
with modest weight loss.
Yeah, yeah. So now, considering modest weight loss, tell me about any new developments in surgery which can deliver an effective intervention, which perhaps doesn't give quite as much weight loss as, say, a typical bypass, because those in the future might be used more often than the ones that we've currently used in the recent past. What are the new developments?
So apart from what we used to use before and we still use, so for example, balloons, then we have got the endo barrier, which was being used at some point, but currently endoscopic is limited, but we have got endoscopic sleeve gastroplasty. It does not remove the remainder of the stomach, but reduces the capacity of the stomach, a bit like the gastric plication that came in about 10 years ago, 15 years ago. We used to do a lot of gastric plication. So they have got their own roles, and in a limited number of patients, they are certainly beneficial. But long term, the results, we have to wait and see. We need at least a 10-year follow-up to see what happens. And at the moment, the gold standard for weight loss remains the gastric bypass, and then the rest of them are compared with the gastric bypass.
Mm-hmm, mm-hmm.
Anything, including endoscopy.
Yeah. Now, as you're aware, the audience who are listening are across the globe, but particularly based in South Asia and also in East Asia. And the availability of bariatric surgery in different countries does vary, and sometimes it's perhaps largely available in the private sector. But the evidence from all the work that's been done is just as applicable, I guess. Or are there any particular observations that need to be made about the use of bariatric surgery in other parts of the world?
Well, it should be done wherever it is done. It should be done in the right environment with the right team. It is quite possible to provide the support that is required remotely. One of the advantages that we have got now with the pandemic, that we now practice a lot of medicine remotely. So it's possible for us to provide support for patients who may not be able to travel to the main hospital, but they are being perhaps treated after their operation, or being supported via remote software, whether it's Zoom or Teams or Google Meet. It is possible to do that, but it is really important that it's done properly and the team are trained properly. And it does not have to be delivered. The post-op care does not have to be delivered by a hospital team. It can be done even in the community by appropriately trained community team. In our hospital, we have trained our nurses and dietitians to an extent where we are confident and comfortable leaving even new patients in the hands of dietitians and nurses, and only just coming and saying hello before the operation, because they will work the patients up. They will identify problems. They will deal with these things. So it's a matter of training up. In fact, we are very proud that in our hospital, our nurses and dietitians are now trained up to prescribe medications. Our nurses can endoscope and they can perform endoscopy. It is not now necessary for a doctor to do it. We can depend on our AHPs, allied health professionals. So there are things that can be done depending on the health setting that the care is being delivered. And the care that is being delivered in, let's say, I originally come from Bangladesh, even though I was born in Pakistan, but I assume that in Bangladesh or Pakistan, the care would be delivered through a different setup than what is going to be delivered here in the UK. And there's nothing wrong about it, as long as it's done properly.
Mm-hmm. So in actual fact, that sort of touches on the concept of health tourism, where a patient might be assessed at a local expert hub and then be sent off somewhere else for the surgery, but their management would be back at home in their home district by local individuals. And health tourism does occur in Europe, doesn't it? In the sense that we know that about, I think it's maybe up to 6,000 UK patients who have been on the waiting list for a long time actually choose to go to other European countries for their bariatric surgery. So this is something that has been developing for some years.
It has been. The problem that we have, of course, is because there are no quality control. So patients quite a lot of time end up going abroad and getting their treatment, and they may get it in a good environment, but they might also get their treatment in dubious environments. So, for example, here in the UK, if someone is symptomatic reflux, we would never think and imagine doing a sleeve gastrectomy for this patient. But we regularly see patients that have gone to Turkey and have come back with a sleeve gastrectomy with a clear history that they had reflux before, but no one bothered to investigate that. No one bothered to advise the patients of the possible complications that they would. And then, of course, we in our health environment are having to deal with these. I had a gastric balloon removal this morning in my endoscopy, which had the balloon inserted in Turkey. Obviously, patient has become unwell, cannot go back to Turkey to have the balloon removed, and therefore we in the NHS are having to deal with that. So in an ideal world, there is a clear understanding and a clear setup. There is nothing wrong in patients being treated abroad, as if the treatment is done by appropriately qualified people under the right sort of circumstances, right setup, and that's really crucial. Again, number of times I've seen patients who have had their bariatric surgery in Iran, and they come back, or Colombia, and they come back and they present to our hospital 3 years later with complications, and we ask them about vitamins and minerals, and that's the first time they're hearing of vitamins and minerals. No one actually has spoken to them about these, and so that is really important that is factored in the management of these patients.
Yeah. So I'm going to conclude by asking you to elaborate on a question that I often ask people. I think I've asked you before. If we were to put you in a situation where resources were unlimited, in other words, you could set up whatever you wanted to, and you could make all the arrangements and employ all the staff who were needed, how would you like to see, what would you like to do if you had unlimited responsibility? You might want to answer it in a research context, because there may be some outstanding question, or just in terms of management, delivery of good services. So what would you do if resources were not a limiting factor? What would you like to do?
So there's so many things that we could do. If resources were not a limiting factor, of course, we would be investing in research. That is really important, because we would always be able to develop and deliver better service in future. But for now, I certainly would concentrate on having a long-term strategy. So community involvement, so that the people are taught the right diet, what is good for us and what is not good for us. As we know, that's a great debate, so-called nanny state, but I think that it is our responsibility to make sure that people understand the consequences of the food choices we make. I come from Bangladesh. When I grew up there, people ate healthy food, and if I go there now, it is almost always unhealthy food, fast food. So community prevention is important. So the education in the schools, making sure that we have got the right setup, so that we have got cycle lanes, people walk. Then we encourage people to go to work and do that through some sort of physical activity, rather than just sit in a cab or a car or just in a bus. So we need to encourage these things. Then, of course, we should be also encouraging a holistic health system, so that at every contact with the health system, people are talking about weight. I mean, up until 10, 15 years ago, I don't think that weight was on the radar of people. Smoking was, but no one actually said, well, actually, you know what? You are a bit, you are veering towards becoming an unhealthy weight, and maybe you should start making some changes now. So that should be the job of the nurses that visit schools, the GPs, and so on. And then, of course, access to medication is important. at the right time rather than when it's too late. In an effect, in a sort of long-term strategy. So if that means that we need to go for generics, then so be it. But of course, I understand that these medicines are developed after billions of pounds of research or dollars of research, and they will have to reclaim this. But eventually, the medicines should be cheap enough so that they can be offered in a larger group of people. And then, of course, surgery for those patients who need it, because just like anything, treatment for arthritis does not take away the need for hip replacements. My glasses does not take away the need for surgery to restore vision in some patients, cataract surgery and so on. So there will always be the need for surgery, but hopefully we would be able to use our resources more effectively. That should be the aim, a long-term holistic look as to what we can offer as a society rather than just individual units.
So what you're really saying is the provision of adequate services at the appropriate point, but actually looking a little bit earlier in the process in which problems develop. In other words, looking at prevention much more than we do, because we tend to be reactive rather than looking to try to prevent various things. A lot of good work has been done, though, hasn't it? When you think about, for example, in cardiovascular disease, the use of medications for treating cardiovascular risk factors has changed the pattern and timing and ages of cardiovascular disease quite dramatically. So it has happened, it can happen. So hopefully with regard to obesity, maybe the same could be done, early intervention.
Yes, absolutely. If there's a societal recognition, but I think it's only now that obesity is being considered as a disease. I mean, when I grew up in Bangladesh, and even I think 15, 20 years ago in this country, having a beer belly was considered completely normal. No one thought that it was an abnormal thing, walking around, and that is what was expected. But it is now that we're recognizing that it is not only the weight but also the abdominal girth that tells us that we are on the wrong path. So yeah, these sort of things being more widely available. I would make health information available on the food packaging. When we are buying a bar of chocolate, is it good for us, bad for us? How much do I need to walk in order to burn up that bar of chocolate? Sadly, the commercial forces are so great that they would fight tooth and nail to have that information available. As you know, they would not like you to know that a biscuit is 40 minutes of walking. They would rather that you have 5 biscuits rather than 1 biscuit. That's the problem.
Yeah. Now, final observation. I do know from messages that I've received that the final year medical students and graduates at Lahore and a number of the other medical students at medical colleges in Pakistan actually do watch these interviews. So for a young new graduate who's interested in surgery and who's interested in upper gastrointestinal surgery and thinking of maybe becoming a bariatric surgeon, at this point in time, would you say do that, or would you say maybe concentrate on something else? Do you have any specific advice?
Absolutely do it. It's still a great rewarding specialty, and I enjoy it. When I started doing it, there was much less access. It is now much more available, much more recognized by all specialties. So I think that this is an exciting time to be a surgeon still, and a very exciting time to be a bariatric surgeon.
Fine. Thank you very much indeed, Mr. Sufi. Thank you for talking to us. Most grateful to you. Thank you. Bye-bye. Bye-bye. Bye.
Bye-bye.